I have a very interesting topic that I'd like to speak on today, and is weight a good criteria for measurement of obesity? And my contention is that it's perhaps a fallacious criteria, and we should look at better markers. Now, we know that over a period of time, we have stopped recognizing obesity as just a cosmetic disease, but it has far more implications than just being a cosmetic aberration. Today, all the world societies do recognize the link of obesity with a number of non-communicable diseases like cancer, hypertension, diabetes, cardiovascular disease, and so many other problems. And we should stop recognizing that obesity is not an important problem, because we do know that obesity can lead to multiple other issues. Conventionally, we have classified obesity in the manner that has been shown over here, and this is the international classification. But for Indians, we have lower cutoff points, and you can see here the definition of obesity, which is relevant to our population. So if you see on the left side, we sort of define obesity when the waist circumference in men is more than 90 centimeters, and for women, it is more than 80 centimeters. And when the waist hip ratio for men is more than 0.9, and for women, it is 0.8. When the body fat percentage is more than 25% in men and more than 30% in women. If you look at the table on the right side, here you're looking at the BMI cutoff points. So normal would be between 18.5 and 22.9. That's close to 23. Overweight, anything between 23 to 25. And obesity, the grades 1, 2, 3 would be between 25 to 30, 30 to 35, and more than 35. That's as a matter of convenience. So these are the cutoff points when we talk about from the Indian reference. Now remember that BMI is just basically a ratio between height and weight. It's just a tool for indicating weight status in adults and general health in large populations, but it should not be taken as a measure of body fat. We know that weight comprises often of different body compositions, and here you can see that muscle comprises about 40 to 45%, fat about 15 to 30%, water about 50 to 65%, bones about 15%, and organs and other tissues about 10 to 15%. So when we talk about weight, it encompasses all these compartments. Now, the disadvantage of BMI is that it does not correlate very well with body composition and its relationship to metabolic disease. And it may the fat mass is not represented very well in the BMI, because we know that's a fat mass which is the culprit for development of all the metabolic diseases. It also does not account for increase or decrease in the muscle mass and may overdiagnose obesity in muscular individuals. And the BMI cutoff points do not always distinguish between males and females. So, we need to look at BMI in a distinct manner, which is independent of the fat mass. Now, here's some DEXA measurements that were done from the enhanced population between 1995 to 2004. And what they did show was the correlation of BMI to percentage of body fat in individual patient largely depends on the amount of muscle mass in the individuals. So you see here the BMIs and the total body fat percentages. So you look at the different BMI cutoff points and the body fat for men and women that are relevant with the different BMIs. So we need to look at that. What is the composition of muscle mass in that BMI vis-a-vis the fat mass? So the advantage of body fat measurements is it gives you an accurate assessment of the fat, whether it's visceral fat or subcutaneous fat. And it may be a reasonable longitudinal measure so that when patients are engaged in losing weight, we can actually differentiate that which compartment is actually taking a better shape. Is it the fat mass or the muscle mass? And often what may find that the weight may remain the same, but the fat mass to the muscle mass ratio may change. So the weight may not change, but you may find that the muscle mass may become better and the fat mass may become less. Also, BMI is insufficient to predict mechanical and metabolic consequences. Well, there is a clear outline of the consequences of obesity, and mainly visceral obesity, and its relationship to insulin resistance and other non-communicable diseases like hypertension, dyslipidemia, and diabetes, which are strong cardiovascular disease risk markers. Similarly, patients may look big with a high fat mass and yet may have a reduced muscle mass and strength, what we term as sarcopenia, which may make them prone for the increased risk of falls, disabilities, and fractures. Now, in consequence, you can clearly see that patients who tend to have physical disability and falls and fractures may actually accumulate a lot of fat because of inactivity, and that may make them more obese, increasing the risk of all the cardiovascular risk markers. Now, there is clear evidence to show the correlation of obesity with multiple complications. And based on the strength of evidence, you find that the strongest evidence comes from the problems related to hypertension, cancers, NAFLD, diabetes, congestive heart failures, and erectile dysfunction, mental health, and then of course lower levels of evidence which correlates with number of other problems. So there are almost about 229 plus complications which affect every organ systems and medical specialties. Now, are all obese bad? So we now recognize a term called as metabolic healthy obesity. And I'm not going to talk too much about it over here, but I'm going to refer to my next couple of slides to talk a little more about this. What it just says is that patients may be obese, but are all obese people sick? So there could be a population of people who are obese and yet metabolically healthy. But is it a true normalcy that the patients tend to have is a key question. Today, our approach to diagnosis of obesity is based on the measurements of BMI with waist circumference, body composition analysis, and the Edmonton Obesity Staging Scales to assess obesity. And we're going to talk a little bit of each one of these and what is the evidence that how good they are in diagnosis of obesity. So let's talk about BMI. And all this while we've been talking that is BMI alone sufficient to assess obesity? Now, if you look at this diagram, there's clear three-compartment definition of normal body mass index, overweight and obese individuals, and morbid obesity. But sandwich within the normal body mass is another class which we call as normal weight obesity. And these are the typical Asian Indian populations where we find that they may have normal weight and yet a higher amount of adiposities. And these are typically what we define as thin fat Indians. This 2x2 diagram actually gives you a better perspective where we know that based on BMI, you may classify patients as normal weight or obese, and based on metabolic status, metabolically healthy or unhealthy. Now, if you do a 2x2 correlate where you have normal weight and metabolically healthy people, that's the preferred, that's about 26% of our population. And you may have normal weight and metabolically unhealthy, and that's what we term like an Asian phenotype. These are 8%, and these have a strong correlate to excess of visceral fat, insulin resistance, diabetes, sarcopenia, high inflammatory markers, high cardiovascular risk, and high cancer risk. On the other hand, you may have obese and yet metabolically healthy, these are 10%. And you may have obese who are metabolically unhealthy, which are a large population of people. That's about 21%. And they have excess visceral versus subcutaneous fat, hyperinsulinemia, diabetes, sarcopenia, dyslipidemia, high cardiovascular risk, high cancer risk. In between, we have metabolically healthy and overweight, and metabolically unhealthy and overweight. And these are roughly about 18 and 17% of our populations. So as I referred to earlier, a concept of metabolic healthy obese, and these are patients who have a BMI of more than or equal to 30. They have a normal cardiovascular risk profile with no increased risk for atherosclerosis or hypertension. There's an absence of dyslipidemia or hyperuricemia, and they have normal insulin sensitivity with the preserved glucose disposal, no increased risk for type 2 diabetes. But it's kind of paradoxical. And truly speaking, when you look at all the research papers, they're not really metabolically healthy, and invariably they tend to have one metabolic condition or risk factors. This was an excellent systematic review, meta-analysis of studies that looked at the performance of body mass index to detect body adiposities. So there were 25 studies. They assessed about 31,000 patients between 1990 and 2008. And what they did find is that half of individuals who had excessive body fat percentage were labeled as non-obese, and 10% of those studied individuals were misdiagnosed as obese. And to identify excess adiposity, when you look at the sensitivity and specificity, it's not very good, 0.5 and 0.9. So the conclusion was that an excess of percentage of body fat has been associated with metabolic dysregulation, regardless of the body weight. And that's clear from our understanding of various studies. And BMI should not be considered as the only measure of obesity in patient care settings. As I referred earlier to you, the thin fat Indians, which a concept was brought out by Dr. Yagnik, and he compared the non-Asian population. And for the same BMI, the Asian Indian population had a higher amount of adiposities. So we tend to accumulate a lot of adipose tissue around the midriff and in all the organs. And we have a lot of central adiposity with a lean muscle mass and a bone mineral, which is lower than other ethnic groups. There are further limitations of BMI because it does not assess the presence of concomitant comorbid conditions or disease risk. It does not measure functionality, quality of life, or prognostic contextual factors. And changes in BMI or waist circumference does not necessarily reflect in overall health or functioning. Let us find out better markers or measures for BMI rather than BMI alone for assessment of obesity. So today, in clinic settings, we talk about BMI with waist circumference. For those institutes that have body composition analysis, how good are they? And then can we combine it with the Edmonton Obesity Staging Scale, which I'm going to talk about in a short while. So talking about BMI and waist circumference, we had an Indian guideline that was put out by Dr. Mishra and group, and they said that we should measure both the BMI and the waist circumference because the waist circumference reflects central adiposity. And we know that as an Asian Indian population, we tend to have a high amount of visceral adiposity, which is sort of marked out by central adiposity, which has better correlation with metabolic and cardiovascular risk stratifications. This has also been reflected in the ACE guidelines, which does mention that in ethnic groups like South Asians, individuals with BMI between 23 to 25 can still be diagnosed as obese and should be evaluated with measurement of waist circumference because of the high population ethnic specificity threshold values as delineated by the IDF. It also, the same guideline or consensus statement talks of waist circumference cutoff points for Asian Indian, and they have an action level 1 and action level 2. So the action level 1 is men waist circumference more than 78 and women more than 72, and these are people who should avoid gaining weight and maintain the physical activity to avoid acquiring any of the cardiovascular risk factors. Whereas action level 2 are higher cutoff points of waist circumference more than 90 and 18 men and women. And these are obviously obese individuals who should seek medical help and assess for all the obesity risk factors as well as cardiovascular risk factors, and they should be managed very aggressively. I want to come to now body composition analysis because it's gaining a lot of recognition and more people are opting to look at body composition rather than BMI. And today, with all the bioimpedance devices that we tend to have, we can get a fairly accurate estimations of the fat mass, muscle mass, and the water mass, which sort of gives us an accurate assessment of what comprises the weight. The rationale for this analysis is also because it characterizes the nature and degree of diseases such as obesity and undernutrition, and it helps the clinician to monitor the treatment safety and progress. Now, there are 5-level body compartment models for body composition. So one is atomic. So you've got all those elements that make the atomic composition. Then the molecular composition, which is measured by water, lipid, protein, carbohydrates, and bone mineral soft tissue. Then you've got cellular models of body composition, tissue system analysis, where you've got the adipose tissue, skeletal muscle mass, visceral organs, bone, and other tissues. And then the whole body compartment models as a measure for body composition. So they look segment-wise. So the head, neck, trunk, upper and lower extremities. And this is how you look at the different body composition. The cutoff points for percentage of body fat as measured by or as outlined by the Obesity Medicine Association, the acceptable norms for women are between 25 to 29%, and for men between 20 to 25%. Pre-obesity is between 30 to 35%, and for men between 25 to 29%, and obesity more than equal to 35% for women and more than equal to 30%. And it's also been sort of classified based on android fat and visceral fat distribution. So, which is sort of the distribution of visceral and abdominal subcutaneous fat. And these are the cutoff points as mentioned in the table for women and men. The last part that I want to talk about for assessment of obesity is the Edmonton Obesity Staging Scale, which has now gained a lot of popularity because it encompasses not only the weight, but it looks at the medical correlates, the mental assessments, and the functional limitations a person may tend to have. And it sort of complements the three, and patient moves from good to bad, from stage 0 to stage 4. And this gives you a lot of assessment of the patient, not only in terms of how obesity is affecting an individual patient in terms of medical sort of comorbidities, but also in terms of functionality. And here's a clear example from the study. They looked at the enhanced 3 population, and they were looking at what is survivals in this cohort based on the BMI classification. And you can see there's a lot of clustering of all these different sort of cohorts when you looked at it from the enhanced population, from a survival benefit, from the survival or from the mortality point of view. Now, the same cohort, when you apply the Edmonton Obesity Staging Scale, you get a good separation, and you know that patients who have stage 0 are probably at a lower risk for mortality as compared with a higher staging scale, which has a higher incidence of mortality. So clearly, you get a better separation on functionality, comorbidities, and mental status when you look at the Edmonton staging. So it independently predicts mortality even after adjustments for contemporary methods for classifying adiposity. Here's also, when you look at Edmonton staging from various BMI categories in the same enhanced population, you find that in the same BMI category, people with obesity are staged differently and may need a different therapy for obesity management, irrespective of the BMI. I talked about normal weight obesity, and this is typically thin fat Indians that we talked about, where they have a normal body weight and a high adiposity. And there is a very good sort of viewpoint that we talk about the KG-A1C paradox, where you have individuals with low or normal BMI and a high prevalence of diabetes. And on the other hand, you may have individuals who have a high BMI and lower incidence of type 2 diabetes. And family history of diabetes just makes things worse because it just raises the higher prevalence when you have a family history of diabetes. So you have different cohorts of people. Now, obviously, when you accumulate fat, a lot of fat is first accumulated in the subcutaneous. And when the fat stores are saturated, there's a fat overflow that happens, and it gets accumulated in the visceral fat and deposits at the other ectopic sites. There's a dynamic correlation between the subcutaneous and the visceral fat. Now, the threshold for the spillover is, based on genetic and ethnic predisposition for a lesser, storage capacity. So you find that when you have a predisposition for, with a higher sort of genetic and ethnic predisposition, the subcutaneous fat gets saturated at low thresholds, and there's a higher fat spillover in the ectopic sites, which promotes sort of, a high amount of ectopic fat, which promotes insulin resistance, systemic inflammation, and atherosclerosis. Now, this concept has also been sort of published in various other articles, as you can see from that is seen on the screen. Important is that the people who have a high amount of adiposity has a higher risk, cardiometabolic risk, even with normal weight obesity. So here's a very meta-analysis of various studies, and one of them is from Nitin, who's probably in the audience, where you can clearly see that patients who have a high amount of adiposity, although they may be normal weight, have a high amount of cardiometabolic risk based on just the adiposities. So I just want to end up here and summarize to say that assessment of obesity with BMI classification alone may not be sufficient to optimize treatment. The body composition analysis helps in identifying people at risk of complications due to body composition disorders, which are neglected by the conventional BMI assessment. Edmonton staging is a simple, disease-related, and functional staging system that would provide additional clinical information to guide and evaluate treatment for people with obesity. I would like to thank the organizers and everybody for giving me this opportunity to speak, and good luck for the meeting.